Well, good morning, friends. Now, in continuity of radiation oncology stepwise progress, now our next lecture is a continuity of image guidance radiotherapy, highly conformal radiotherapy. So, we'll be dealing with this regarding the conformal radiotherapy and image guided radiotherapy. The IGRT, image guided radiotherapy, imaging technology and its solution, imaging methods used in IGRT treatment has been categorically divided into non-radiation based imaging system and radiation based imaging system. What all are the non-radiation based imaging system are USG based system, infrared camera based tracking system, electromagnetic transponder based tracking system, and MRI based imaging system. All four you know very well that they do not produce ionizing radiation. This is safe for a pregnant woman. The radiation based imaging system consists of electronic portal imaging devices which is inbuilt in the linear accelerator, cone beam CT and FAM beam CT on rail or FAM beam mega voltage. So FAM beam having kilo voltage, that is called CT on rails, and the FAM beam mega voltage based CT, that is also termed as a tomotherapy for real time 4D tracking, that is utilized in a CyberKnife and real time tumor tracking system. So these are the radiation based imaging system. We will cover one by one. So non-radiation based imaging system, the ultrasound based system, basically we acquire the 3D image with the help to align the target to correct intrafractional error, and that is can be done in the room because nowadays the modern linear accelerator high end, they have a, you see the transabdominal probe, transperineal probe, which help you to take a image just prior to the delivery of radiotherapy. So this USG based system quite possibly used in the prostate and lung cancers. The infrared camera based tracking system, this system identify the patient reference setup point in compared to the planned CT setup point which we have already planned, and now which aids during the treatment delivery to align the treatment isocenter with already planned CT imaging system. So it's basically a counter check by infrared camera system what we have planned earlier and what we are getting, so that we correct the this gap correction. The infrared camera based imaging system also used for a intrafractional positional monitoring for a gating treatment, and only when the tumor is moving, the setup position for a gate used for a repositioning correction. So either it can be used for a gating method or for repositioning correction methods. That's infrared camera for a moving tubers. It can be utilized. The system used in the treatment of prostate cancer, breast cancer, respiratory gating used with the help of external surrogates, because external surface may act as a reliable surrogates for an internal organ motion, presuming under the limited situation. I please underline under the limited situation where the external surrogate can be used or considered as a reliable method of choice. So here you see electromagnetic infrared camera system. You see here the video camera, infrared cameras are there on the in the room ceiling mounted there, and you have a reference point and then the markers, infrared markers put on the patient surface for a tracking and these all the images is being transferred to the console in the 4D to the treatment planning system in order to better delineate the tumor and then correction, recorrection, and a counter check. So electromagnetic image tracking system, also called CALYPSO system. This system used to have electromagnetic transponders, that is called beacons, embedded within the tumor, and the motion of these beacons may be tracked because the organ motion that the beacons will move, so that if we are going to intended to give a radiotherapy to that moving organ, the beacons will also move and it will be tracked by the electromagnetic imaging system. So beacons need to be placed in the tumor via minimal invasive procedure, but their presence produces the artifact, particularly in the MR images, and that's why its use is limited up to the prostate cancer. So you see here the beacons. The beacons are implanted in the pelvic in this lady sitting, and then you have an infrared cameras and electromagnetic rays to take the movement of a beacons, and the image is transferred by 4D tracking stations, that is advanced treatment planning system, and where the correction is done on counter check is done. The entire image guided radiotherapy is counter checking the image guidance with the help of highly sophisticated imaging system. That is the basic philosophy behind the image guided radiotherapy. So now what are the MRI in non-radiation based category? The MRI based image guided radiotherapy system, the real time assessment of internal soft tissue anatomy and motion is being utilized, because MRI is best for the soft tissue, and so MRI allows intrafractional correction by moving the soft tissue organs or soft tissue tumor inside. However, this system has limitations because the motion artifacts cannot be performed in the patient. Those who are having pacemakers, these having a metallic implants, dental implants, so its limitation is there. Now we'll cover up the radiation based imaging system used in IGRT. That first is EPID, that is electronic portal imaging devices. The EPID was developed as a replacement of film dosimetry for the treatment field verification. An EPID based detection system is basically an active flat panel image. They offer as a standard inbuilt equipment, usually in all modern linear accelerator. So usually if you buy a modern linear accelerator, the API inbuilt is there already. So what you get an image, EPID just merely give you a 2D image, but the image at the time of just before the radiotherapy or during the time of radiotherapy, that can be utilized very. The bony landmarks, planar image are used as a surrogates for defining the positional verification in reference to digitally reconstructed radiograph, which is being already done. So that is the beauty of EPID. And DRR usually we get by the help of CT planning data set. So you see the X-ray beam is there and an EPID, and then the beam is delivered, and then the 2D image is being formed by the electronic portal imaging devices. Some modern electronic portal imaging devices do also have a dosimetry. We can assess the dose received this thing, but the more precisely it is used for the imaging system. So this figure is showing about this like the typical radiation source, and sometimes radiation source is used as for the treatment as well as diagnostic, and the image guided portion, the low energy beam. which will be telling you the next slide, and then the camera lens is there, and then image is transferred to 4D planning system, which I've already described you. The PID system may use the kV imaging or a mega voltage imaging. Image contrast seen better with kV imaging. Also, kV imaging produce image with a lesser distortion from metallic implant. So the artifact is not there, very less in kV imaging. But if you do the mega voltage beam utilized for the imaging by the help of a PID, so that the problem with the lesser contrast images produced, which we cannot define very clearly, visualization is a problem, and the more distortion from metallic implant and artifacts is produced. Like in a dental implants, for head and neck cancer, hip prosthesis in pelvic tumor, which is commonly seen with the mega voltage imaging, these artifacts. The only limitation of PID system, they cannot detect or quantify the rotation. That is the only limitation. The cone beam CT is again as a radiation based imaging system used in a image guided radiotherapy. The system is actually linear accelerator clubbed with this cone beam CT. A volumetric images are generated in a one rotation. So there is no interscan delay, there is no missing one slice, the slice uniformity is good, so which is very good for this thing, for radiotherapy planning. Which this image can be compared with the planning data set for correction in cone beam CT, gantry rotation around the crotch. According to the average position of organ to organ with respiratory motion, both interfraction, setup changes, and anatomical changes related to weight loss of patient after few fraction of radiotherapy, or organ filling like a bladder and rectal filling may lead to the movement of a prostate cancer. So we can, by the help of cone beam CT image, solve these problems. So you see the cone beam CT, even rotation, one rotation, you get n number of slices, and then in about the other traditional CT scan, you one rotation produce one slice, so the multiple rotations, so there might be interscan delay, the slight like not a uniformity in the section of the slicing of a CT scan may be a problem, but this problem is solved here in the cone beam CT. The repeat scanning at the end of a treatment may give an estimate of intrafractional changes. Yes, that is very true, and the system also help in the treatment response evaluation. Like you go for imaging, continuous daily online imaging or offline imaging, you can also get an information other than a tumor, that how much tumor is got shrunken and what are the response in the tumor, and can we use to the can we go with the old treatment plan or a new plan is required. This leaves the scope for adaptive radiotherapy. The fan beam CT, that's CT on rail, the system in room, CT scanner, its gantry move along the couch and 3D images are taken with the patient is immobilized on a couch. It's different from diagnostic CT because the fan beam CT scanner having a wide bore, basically a typical CT simulator types, and have a wide bore aperture more than 80 centimeter to accommodate the bulky immobilization devices like a woman with a breastbone has to go for a CT imaging, or head and neck cancer patient along with the head and neck rest along with the orphic cost, we required to have an image. A diagnostic CT usually having aperture not required these things, so that they are usually having aperture 70 centimeter only. So was I was telling about the images which we get in a like a mega voltage image and a kV image difference. You see here in the picture the KV image contrast is much better shown, and the mega voltage the contrast picture is not shown very good. So here the both CT and an inbuilt CT linear accelerator is there, so that the patient, the same linear accelerator, low energy is used for the imaging purpose, and high beam high energy is used for the tumor coverage. The fan beam CT, or that is tomotherapy, this system include onboard imaging system to obtain a mega voltage CT image. The patient, while patient is the treatment position on the couch, the same LINAC used to generate 6 MV for treatment purpose and 3.5 mega voltage for imaging purpose. So you see the fan beam CT scan, one rotation is one section of a slice, but the cone beam CT, one rotation gives a multiple volume of an organ is scanned in one rotation. Now I'll be taking you to the real-time 4D tracking system, that is CyberKnife, the most advanced version of a radiotherapy. As of now, the CyberKnife system consists of a compact linear accelerator mounted on a robotic manipulator arm, which direct the radiation beam to the desired target volume based on the input from two orthogonal imaging systems mounted on the ceiling of the room. This ceiling on the room with a flat panel floor as a detector on either side of the couch to acquire the image, transfer the image to the treatment planning system console, to the treatment planning system, so that we can real time during the radiotherapy we keep tracking the tumor and the correction is made. Images are required throughout the treatment duration. That is why called real-time tracking system. Couch, robotic head, you can say gantry, couch are guided through an automatic process. Several tracking methods may be used depending on the tumor treatment site. You see here the CyberKnife system. You can see on the floor the flat panel detector system of a KV imaging, but on one side you can't see this thing. Basically the X-ray mounted on the KV for KV imaging on the roof of this room. So now I'll be taking you to the few points regarding the fiducial marker importance. It needs to be placed within the tumor target, and tumor motion is tracked and correlated for monitoring the fiducial marker position. So the fiducial marker first is put in the tumor, so that one idea you get is the tumor motion image, as well as the fiducial marker also provide the translational rotation, how much rotation is there, and as well as deformation and tumor shrinkage idea you get. Respiratory motion also monitors and accounted for correction of target position and motion. Though the synchrony model generated in the real-time imaging, minor imaging procedures are required if a fiducial marker are needed for tracking. This system used for both cranial frameless radiotherapy, no head frame, and then extracranial radiosurgery, SRS and SRT. What is all about the real-time tumor tracking system? The system is designed for real-time tumor tracking by help of imaging of implanted fiducial marker, using this information for gating purpose as well. It is basically consists of 4 X-ray camera unit mounted on the floor, and the ceiling mounted image intensifier just reverse to the position and opposite to the CyberKnife system, where the image intensifier is basically is there on the floor, and then the X-ray cameras are there on the roof, but here is the reverse. The LINAC head of a beam is gated to radiate the tumor when the implanted marker fall within the tumors or fall within the planned treatment field. So, IGRT technology implementation, the fiducial markers serve as a surrogate for a soft tissue target when they are difficult to visualize. When the organs are difficult to visualize, the fiducial markers are put for their movement and alignment, and their alignment, if that tumor alignment cannot be done with the help of bony landmarks, then these fiducial markers is highly required. These markers may be tracked in the real time to obtain 3D coordinate for target correlation. You see here the fiducial marker implanted here particularly in the lung cancer patients, and then you see here the difference of reference in the daily radiotherapy online imaging. You see the difference, so that you require to need correction in that. So there are gold fiducial markers, and then have an implantation gun, so that with the help of these devices, this fiducial marker can be put in the tumor. So moving target volume delineation, how we delineate that moving target volume, like the intrafractional target volume motion or intrafractional target volume motion, displacement, deformation, change the shape of a tumor, or alteration of a target should be accounted during the determination of PTV. This process starts from beginning of a CT simulation for that particular tumor and goes up to the end of a radiotherapy treatment. Patient positioning is also very vital. Ensure the accuracy of patient positioning and its daily reproducibility for a fractionated treatment in reference to the chosen image-guided radiotherapy device, as well as the radiotherapy treatment unit and a type of machine. So image acquisition system should be calibrated to ensure the high quality imaging with attention to the slice thickness uniformity. That is very important. And image contrast resolution should be very good. The isocenter alignment between the treatment planning and delivery system also ensure the accuracy of soft tissue, where use a correlation of couch misalignment. So now image verification, then after the treatment verification, that is dose verification, image review by the radiation oncology as what fraction and then periodically, as well as it's necessary to ensure the treatment accuracy and its reproducibility. There is a record of periodic verification must be maintained, like how much correction you have done in a particular site of a tumor. So the department can have on a particular site of a tumor a threshold of a data in their bag, that how much we need to correct this particular site of a tumor. So we give basically an idea, as well as data sets serve as a guide of modification the process involved in subsequent same site radiotherapy planning. The same thing I explained you. The all was not very good in the IGRT. What are the current limitation of image guided radiotherapy? Proper selection of the patient. Those who required image guided radiotherapy must be identified. Other problem is limited availability of experienced staff is a major concern. In terms of quality control decision, whether to go with the new plan or continue the original plan always remains a dilemma. Daily online treatment imaging of a patient before treatment makes unnecessary radiation exposure and is threat to development of a malignancy. But this concern was removed with the advent of MR-based linear accelerator. Thank you very much for your kind attention.